Today's lecture class is on host modulatory therapy. So these are the learning outcomes. We'll be discussing on the concept of host modulation therapy, what are the agents which are used, and in main we'll be concentrating on NSAIDs, periostat, that is doxycycline, and chemically modified tetracyclines. So to start with, host can be defined as an organism from which a parasite obtains nourishment. In other words, modulation can be termed as the alteration of function.
So now coming for the model for pathogenesis of periodontitis. So several authors they had come with the conclusion telling that microbial challenge is the main status for the main reason for the clinical signs of diseases of initiation as well as progression, which means that it is just because of the microbes that there is signs of disease present in the oral cavity. Periodontitis is occurring. But further, the authors came to a conclusion that for each of the microbial challenge, there is going to be some host response which is going to be occurring. So this is both going to be an immune mediated as well as an inflammatory mediated response. So because of this that is then host immunoinflammatory response, so this results in clinical signs of the disease. So this was the next set of theory which school of thought which came into existence. But at last there was a person called as Kahneman, where he came up with a model for what is actually occurring in periodontitis and why the condition is occurring. So to put it in short form, we will be explaining about this again in the later slides. So I will just tell in short form what generally pathogenesis of periodontitis is. So here, whenever we face dental plaque is left out without cleaning in the oral cavity, the microbial challenge is left open. So which means that from the dental plaque, the antigens and the lipopolysaccharides and the other virulence factors from the microbes are released into the oral cavity, that is into the host. So host, that is we tend to give an immune as well as an inflammatory response. So in this response, we tend to give out antibodies and neutrophils. So because of this release of antibodies, we don't only release antibodies and neutrophils. Along with this, we tend to release certain immune mediators also, such as cytokines, prostanoids, and matrix metalloproteinases. So these three, they don't only destroy the microbes, but also tend to destroy our own connective tissue also. So it is like an autoimmune response which is occurring. So because of that, there is connective tissue as well as bone metabolism is getting disrupted. In other words, it is getting a problem is there. The problem starts, and therefore there is clinical signs of diseases. Again, so this is not the only mechanism which is taking place. It has also been reinforced that there could be certain genetic risk factors which play a role in the response which the host gives, or how the tissue changes takes place in the body. Apart from that, there are some environmental and acquired risk factors also, such as your smoking, diabetes. So all this tend to influence the host response as well as the connective tissue changes. So at last, because of all these factors, you see the clinical signs of diseases which are present. So to put it in short form, it is not only the bacteria which causes the disease, but it is also the host who is not able to compete with the amount of inflammatory factors which is being produced, results in clinical signs of the disease. So this is what we will be seeing in this particular class. So the model of pathogenesis, periodontal pathogenesis has been already explained before. But there are certain individuals, though they have so much amount of inflammatory factors like plaque or calculus, they don't get disease itself. Whereas on the other hand, there are few individuals that even if they have little amount of plaque, they have hell lot of infection. Why is that so? So immune response to the bacterial challenge never occurs in isolation, but takes place in the context of the other host and environmental factors that influence these responses and thereby determine the progression of the disease. So here is the a curve where inflammatory response characteristics in relation to the bacterial challenge. A given bacterial challenge results in differing level of inflammatory response according to the response profile of an individual. Most of the people are close to this normal and produce a certain level of inflammatory mediators for the given challenge. But those who are very hyper responders generate an excessive inflammatory response to the same bacterial challenge and cross the threshold into an active disease at an earlier stage itself. So those who are hypo-responsive produce lower level of inflammatory mediators and despite a significant bacterial challenge may never develop peritonitis. So this is what the authors found, that you could have either hyper-responsive individuals, normal responsive individuals, or hyper-responsive individuals.
So accordingly, for the peritonitis, the model of pathogenesis was refabricated like this way.
So based on all this, the concept of host susceptibility to treatment planning came into plan. So in the disease status, it has been found, so this is a balance. So if this balance is disrupted, then you end up in the disease. So in the case of health, you must not, you generally you have reduction of the risk factors. You have more amount of anti-inflammatory or protective mediators such as interleukin 4, interleukin 10, etc. With host modulation therapy, resolution of inflammation, and therapy from the professionals if it is there, then you have a healthy status. But on the other hand, if it is going to be more amount of risk factors like genetics, smoking, diabetes, overproduction or pro-inflammatory mediators are more, underactivity of the host response, poor compliance or plaque control, subgingival microbial burden is low, then you have a disease status. So just go through the linings which I have given underneath. So this tells about this balance between the disease and health. So if there is going to be more components on the disease side, then the graph is going to shift to the diseased aspect. If it is going to be more components on the health side.
So based on this, coming out of the rationale of host modulatory therapy, it is to modulate or reduce the destruction, form an adjunct to conventional periodontal treatments, especially your scaling and root cleaning foremost, and if possible, if you're doing any access flap surgery in individuals who are immunocompromised, or if they are refractory to the periodontal treatment, so this host modulatory therapy can be an adjunct. Uh, Basically, the most important part of this therapy is that it does not switch off the normal defense mechanisms. So that is very important when we are giving such host modulatory therapy. So what does it basically do? It actually tries to regulate the mediators that are destroying the extracellular matrix of the gingiva, and also mediators that cause resorption of bone. So these two mediators it tries to suppress by increasing the host response, by modulating the host response. So what are the host modulating agents? A variety of classes have been evaluated of drugs, and based on that they have classified it as systemically administered agents and locally administered agents. Again, locally administered agent can be a part of local drug delivery too. Coming on to the systemically administered agents, you have the non-steroidal anti-inflammatory drugs, bisphosphonates, sub-antimicrobial dose doxycycline, locally administered agents, which includes your topical NSAIDs, enamel matrix proteins, growth factors, bone matrix proteins, and then tetracyclines. So you have a picture here, the Conman's model already explained to you guys. So the next is about what all can we do so that we can reduce the signs of infection. So the first thing is that we can go about with the controlling of the microbial challenge with the help of antimicrobials. You have your antibiotics, you have your antiviral drugs if it is a viral infection, antifungal drugs if it's a fungal infection. So any of this, the bacterial component can be combated, or the microbial component can be combated by your antimicrobials. Next, coming on to the host cells. So the host cells are the ones which are going to give your cytokines, prostanoids, and MMPs. And these three, not only they're protective, they're also destructive to your connective tissues. So this was what I was telling before. So in that case, what all can be given to suppress, not totally suppress, to modulate these agents? So one is when prostaglandin is increased, that is PGE2 especially. So you can give NSAIDs or periostat as an agent to control the prostaglandins. Cytokines, you can give anti-cytokine drugs, or cytokines have an effect on osteoclast. When osteoclast gets activated, there is going to be bone resorption. So indirectly, we can give bisphosphonates or periostats so that they suppress the effect of osteoclast. Next, the matrix metalloproteinases. This can be again suppressed by the presence of periostat. So what is periostat? I will explain to you later. It is a sub-antimicrobial dose doxycycline. So basically, if you are able to control everything at this process itself, it doesn't go to the next level, that is your bone resorption or connective tissue breakdown. So these both are controlled, then there's not going to be any clinical sequelae present. Okay, next again, it's the same thing. I just wanted to elaborate it in a bigger way, that you do have a microbial challenge which can be cleared with the help of antimicrobial adjuncts, local drug delivery systems, or mechanical treatment. Again, foremost, scaling and root planing is always the gold standard for everything. But along with that, the local drug delivery system could be an adjunct to control the microbial challenge. Next, coming on to the host immune inflammatory responders, anti-cytokine drugs, subdose antimicrobial agents, CMTs can be given, and bone metabolism can be controlled with the help of bisphosphonates. All right. Okay, so to put forward, if there is a reduction of bacterial burden, which can be done with the help of scaling root planing, topical antimicrobial, surgical pocket reduction, along with risk factor modifications, and along with host response modulation. So all these three together can give you a better chance for clinical improvement rather than focusing only on one phase, because always our focus is on only one thing, that is reduction of the bacterial burden. We don't even think of either convincing the patient about his risk factor modification, or telling him that your host is your response is very much hyper to your condition, so let us modulate that. So that all we don't tell him. So in years to come, I think host response modulation will take a major role rather than the uh, antimicrobial supply to the patient. Okay, so starting with the different host modulated drugs, starting with your NSAIDs. NSAIDs inhibit the formation of prostaglandins, including PGE2, which is produced by the neutrophils, macrophages, fibroblasts, gingival epithelial cells in response to LPS, which is a component present on the cell wall of the gram-negative bacteria. In other words, whenever there is a tissue injury which is going to occur, so this tissue injury could be of any form. Just imagine this is happening in your body. Tissue injury could be of any form. It could be a physical tissue injury, or a burn injury, or anything like a bacteria entering inside your body. So any type of injury, or a biological injury which I'm telling. So any type of injury which takes place, what happens is that the membrane phospholipids gets activated, and it starts something called, starts the arachidonic acid cycle pathway. So this is all in your second year pharmacology. We are just brushing up the aspects. Okay, so remember, this is the arachidonic acid pathway which gets activated. So when any injury is there, this pathway gets activated, and this has two mechanisms. One is the lipoxygenase pathway, and another is the cyclooxygenase pathway. So when cyclooxygenase pathway gets activated, what it does is that it results in the release of certain agents called as your prostaglandins. In other words, it is the release of your PGE2, PGF2 alpha, PGI2, and your thromboxanes. So out of all this, PGE2 has been found to be very crucial in inflammatory aspect, especially in the gingival component. So The authors came with the idea that what if we are able to suppress this activity with the help of NSAIDs, this prostaglandin could become reduced in the body so that inflammation reduces. In other words, NSAIDs inhibits the prostaglandin synthesis and therefore it could reduce tissue inflammation was the process. So, non-steroidal anti-inflammatory drugs were given. These were weaker analgesics, non-narcotic or aspirin-like or antipyretic analgesics. So, you can take it for a longer time. They basically do not depress the CNS. They do not produce any physical dependence or abuse liability. They mainly act on the peripheral pain mechanisms and also in CNS to raise the pain threshold. So, because of the inhibition of the cyclooxygenase using NSAIDs, there is going to be an advantage by inhibiting the direct bone resorption activity of PGE2 by modulating the activity of the synergistic agonist. So most commonly researched NSAIDs include your indomethacin and the propionic acid derivatives such as your ibuprofen, naproxen, and fevibrufin. Be not considered as a post-modulatory agent. Okay, since there is already a side effect of gastric irritation in such patients, it has been found that if we give some selective NSAIDs which could not disturb the gastric effects, then it could result in a better acceptance rate from the patients. So what is that? Is that in case of arachidonic acid pathway, there are going to be two pathways which are activated. One is either the cyclooxygenase 1 pathway or cyclooxygenase 2 pathway. So cyclooxygenase 1 pathway, it has generally if this pathway is activated, what happens? This pathway on a normal, there is gastric protection and the platelet function is taken care of by this pathway. So when we are going to disrupt this pathway with the help of NSAIDs, the patient gets gastric irritation. On the other hand, cyclooxygenase 2 pathway has nothing to do with gastric irritation, and therefore you can only give cyclooxygenase 2 pathway instead of giving the traditional NSAIDs like ibuprofen or other pathways, because it doesn't disrupt this COX-1 cycle. So which are the selective COX-2 inhibitors? One is the meloxicam, etodolac, nemisulide, celecoxib, rofecoxib, valdecoxib. So again, they have good potency levels, lesser side effects, but then again long-term use is becoming a problem. So next, coming on to the bisphosphonates. So bisphosphonates, as I told you, they are agents which are going to target the osteoclast and bring down its activity so that resorption doesn't take place. So these are bone-seeking agents that inhibit the bone resorption by disrupting the osteoclast activity. It interferes with the osteoblast metabolism and secretion of lysosomal enzymes. So in animal models, it has been found that bisphosphonates reduce the alveolar bone resorption. In human studies, this has enhanced in alveolar bone status, but then it is not approved due to its complications. So as I told previously, there is an imbalance between matrix metalloproteinases production and matrix metalloproteinases inhibitors, then it results in the disease status. So generally, body itself has certain inhibitors to this presence of matrix proteinases. Those are called as the endogenous inhibitors such as TIMP2, TIMP 1 and alpha 2 macroglobulin. If it is not available in the body, then we can give exogenously by means of doxycycline, chemically modified tetracyclines or bisphosphonates. So this selectively binds the zinc binding capacity of the catalytic domain of MMPs. So as I told already, zinc, it is a zinc dependent proteolytic enzyme. So we are going to bind doxycycline to the zinc area and therefore this gets inactivated. So that is the main theme behind matrix metalloproteinases. So if there is a again to put forward, if there is going to be an imbalance between the matrix metalloproteinases production and the inhibitors, then only we are going to get the disease status. So what we do is that so this inhibitors, since it is less in the body, we try to give it from outside exogenously by means of doxycycline, chemically modified tetracyclines or bisphosphonates. So one method is by sub-antimicrobial dose doxycycline. So you could ask me, doxycycline is an antibiotic. What if you give it for a long time? What will happen to the question of antibiotic resistance? That's why the concept of sub-antimicrobial dose doxycycline came into play. So this is just a 20 milligram dose of doxycycline that is approved and indicated as an adjunct for SRP in treatment of chronic periodontitis. So this could be taken for twice daily for a period of 3 months. It could be taken up to a period of 9 months. Again, to put a word of caution, this is not a standalone therapy. You have to always this is just an adjunct to your scaling and root cleaning. This alone, if you give and you expect periodontitis to get cured, it will not get cured. Alright, so to avoid antibiotic resistance, what do the authors do? They prepared this particular preparation just containing 20 milligram of doxycycline instead of 550 or 100 milligram doses which are available for antibiotic purpose, so that only its anti-collagenase activity is present, not the antibiotic activity, right? So at present, the only host modulation therapy which is recommended and approved by the FDA, accepted by the ADA, is this sub-antimicrobial dose doxycycline, otherwise known as a periostat, and it is available not as an over-counter drug but a prescribed drug for individuals with periodontitis. So the clinical significance, they found that, so when these two was done, there was a clinical attachment gain where compared to the placebo group, and there was also an increased percentage of sites with threshold changes in pocket reduction and clinical attachment gain. Another study also showed that there was the percentage of sites that underwent resolution were greater than compared to the placebo group. So, what are the indications? It could be done in chronic periodontitis cases, given in chronic periodontitis cases, aggressive periodontitis cases, as an adjunct to non-surgical therapy, in patients who are refractory to treatment, that is, they don't respond to treatment, or in patients with risk factors such as smoking, diabetes, osteoporosis, osteopenia, genetic susceptibility, and those in whom the treatment response is limited. It is contraindicated in patients with just normal gingivitis, or in patients where periodontal abscess or periapical abscess or gingival abscess is present, where ideally an antibiotic is needed, and is not to be given in a patient with allergy, pregnant, lactating women, children under 12 years of age, and those people having using the oral contraceptives, that reduces its effect. So as of now, there was no evidence of any adverse effects that could be attributed to the to this drug, since we are not letting going till the antibiotic resistance dose, so there's no problem with this as well. So, what are the mechanism of action of this doxycycline? It has been found. So, it acts at three levels. The first level at the epithelium, it inhibits the production of epithelial-derived MMPs by inhibiting the cellular expression and synthesis. Next, in the connective tissue level, inhibition again of MMPs, inhibition of oxidative activation of latent MMPs, decreases the inflammatory cytokines, scavenges and inhibits the production of reactive oxygen species, and inhibition of MMPs and ROS protects the alpha 1 proteinase and stimulates the fibroblast collagen production. In the bone, it reduces the osteoclast activity, thereby bone resorption, blocks the osteoclast MMPs, and stimulates the osteoblast activity and bone formation. So chemically modified tetracycline, the next one, the unexpected ability of the tetracyclines to inhibit the breakdown of the connective tissue and bone by a non-antimicrobial mechanism was first reported by Golub over 6 decades ago. So it is devoid of antimicrobial activity because the dimethylamino group from the fourth portion has been taken off, and therefore it retains just its anti-collagenase activity. So there were 10 chemically modified tetra, so which is available. So here you can see that the CH3 has been removed from all the places. So you have 10 modified tetracyclines present. So this has been found to be potent collagenolytic inhibitors and effective inhibitors of bone resorption, and blocks PMN collagenase but not bone cell collagenase. These are again not approved for human use. So the main mechanism is that the proposed mechanism of it results from its ability to bind metal ions, particularly Ca+2 and zinc which are required by the enzymes to maintain its proper configuration. Inhibition of active or pro-MMP could occur due to chelation of zinc ions at the binding site in catalytic domain, resulting in disruption of normal conformation of protein structure and leaving it non-functional due to excessive degradation into small molecular weight enzymatically inactive fragments. So there are emerging host modulatory therapies which are coming up, such as recombinant cytokines which can be given, recombinant human interleukin 11, granulocyte colony stimulating factor, NSAIDs which are on studies now are the ketoprofen, the bone metabolism, hormone replacement therapy and calcium supplements, and again MMPs such as the peptidyl hydroxyamic acid derivatives can be given, and again CMTs are also on study right. So in future of HMTs, targeting different aspects of destructive cascade or breakdown events in periodontal tissue are likely to be developed as adjunctive treatments for periodontitis. The further development of these agents will permit dentists to treat specific aspects of the underlying biochemical basis of the periodontal diseases. Thank you.